Hello and welcome everybody to our part two of our mini series. And this topic today is the maxillomandibular relations for all-on-X prosthetics with Dr. Christopher Resnik. Dr. Christopher Resnik is a prosthodontist. He has a private practice in Winter Park, Florida. He is an author and contributing author in Michigan Contemporary Implant Dentistry textbook, as well as avoiding complications in oral implantology. He also is a faculty member as well as clinical director for the Resnik Institute. I want to welcome each and every one of you guys and hand this over to Dr. Christopher Resnik.
Thank you, Dr. Robert, for having me again to talk this evening. Always look forward to this. So we'll get right into it and introduce the panel. That was Dr. Robert. He's the ITX Pros Chief Academic Officer. We also have Dr. AK, the CEO, Dr. Hussein, the CCO of ITX. I believe we have Dr. Peter on. And then we have two of the faculty from the Resnik Implant Institute, Dr. Rick Robinette up in Nashville, and Dr. Tara here in the house. So with that, we'll get right into it. Throughout the webinar, at the bottom of the Zoom here, there is a Q&A. So if you do have any questions throughout about anything we're talking about tonight, anything in implant dentistry, anything about ITX Pros or the Resnik Implant Institute, please feel free to ask questions. One of the faculty members or panelists will be able to answer it. And then also at the end, we will have a little Q&A session with Dr. AK. And you will be getting a CE certificate over the next couple of days from the Institute here. So you will be getting one of those through the email here. With that, we have a lot to talk about tonight. So we're going to jump right into it. Tonight, we're going to be talking about the maxilla-mandibular relations for all-on-X prosthetics. So this is part of our 4 series of topics on all-on-X's. So today we're talking about the maxilla-mandibular relations. So throughout this webinar, we're going to first address some of the complications associated with incorrect relations. We're then going to go through a protocol that we teach at the Institute on how to do it predictably for each patient. And then we're going to finish up talking about techniques that we can use to maintain vertical dimension with all-on-X prosthetics for some conversions, as well as some of the newer digital technologies available to us now. With that, we're going to jump right into some complications and what happens when you violate the maxillomandibular relationship and do it improperly. The most common one's going to be prosthetic failure. Prostheses are going to break. We're only as good as the material is. Zirconia is very strong, but we do have some other materials that we use throughout the temporization that are not as strong and will break. This is probably the most common complication with violating the maxillomandibular relations. And unfortunately, it can be detrimental to the longevity of the case. Aesthetic failure, so where we make prosthetics and we evaluate it from a standpoint where you see the patient at post-op and it's just a failure. The patient's not happy. They don't look like themselves, and you have to remake the prosthesis. It's expensive, several more visits, and something we want to avoid. Speech complications, we put a prosthesis in the mouth and the patient comes back in a week and they're whistling or they can't speak, they're lisping. And then you have to kind of decipher what you need to change to accomplish to prevent that speech complication. Function complications, patient comes in and they just can't eat what they want. They're having difficulty swallowing, just their vertical dimension is way off. TMJ issues, this is severe, but it does happen if you restore a patient at the incorrect vertical or don't recognize their parafunctional habits, and leads to long-term TMJ issues. Implant failure, implants do fail and get overloaded from occlusal overload, and that can happen and pretty much ruin the case. So with that, at the Institute, we have a protocol that we teach and is going to be in the newest textbook here. And we have 4 different segments starting at step 1 here. So we have 4 different parts of the maxillomandibular relation protocol. First, starting with the anterior tooth position. So the first thing we're going to do is set the maxillary anterior tooth. We're then going to determine the occlusal vertical dimension, or the VDO. We'll then go down to the mandible and set the mandibular anterior teeth, and then we will establish the occlusal planes. So we spoke a lot about anterior tooth position during the last webinar in respects to aesthetics, and a lot of it transfers over to the vertical dimension of occlusion and the maxillomandibular relations. But some things to just kind of point out, and one of the common mistakes is restoring the lower arch first. So a patient will come in with an upper denture, their lower teeth are failing, and we just jump to the lower. We don't even really address the upper without realizing that the upper is worn here. And you're then going to restore the upper arch to fit the lower arch, and that will lead to problems. And this is the scenario that we see very frequently. A patient has a worn upper denture that was against lower fixed dentition for many years that is now failing, and a patient desires a new solution. They know from their friends and hopefully from you that lower dentures do not work, and they desire an all-on-X prosthetic. But we need to look at not only the lower failing dentition, but what their upper dentition looks like. And in doing the lower, we also need to reestablish the maxillary anterior tooth position, because that's going to dictate where we place our lower implants and if we do need to do alveoplasty. So not identifying the maxillary anterior tooth position will lead to full arch prosthetic mistakes where we just don't have the correct incisal display for not only aesthetics, phonetics, and function. So again, we always start with the maxillary anterior tooth position. The tooth position will have a direct effect on the vertical dimension, the anterior guidance, the occlusal plane, aesthetics, the mandibular anterior tooth position, and also the posterior planes of occlusion. So that's always going to be our starting point. So we start by making the maxillary plane ideal, and then we restore the mandible. We then jump into our step 2, and this is occlusal vertical dimension. So to just address a couple terms here off the start here, vertical dimension of occlusion is the vertical position when the maxilla and the mandible are contacting, also termed the maximum intercuspation. So when that patient's biting, that's the vertical dimension of occlusion. When they are at rest, that's when the mandible is at rest. So they're not in any stress right there. They're relaxed, also called the physiological rest position. And then we have the interocclusal distance, or the freeway space. That's going to be the difference between the VDO and the VDR. And then we have vertical dimension of speech, and that's going to be the position of the maxilla and mandible when they're enunciating words. And we'll do that in determining the correct vertical dimension of occlusion for our prosthetics. If we look at factors that affect the vertical dimension, obviously the teeth are going to be one of the factors, because we're going to use that to determine our VDO and our VDR. The muscles are going to be what relaxes the jaw there. So that's going to dictate the vertical dimension of occlusion. Then we also have compensatory adaptation. And it's a phenomenon where if a patient wears down their teeth will continuously super erupt to meet each other. So that's why somebody that comes down with worn teeth, they still have all their teeth that are erupting. It doesn't happen in everybody, but it is a phenomenon that does affect the vertical dimension of occlusion. If we jump into assessing the vertical dimension, we have many different techniques out there. You can look in the literature and you'll find endless articles highlighting, this is the best way to do vertical dimension. Or you go to a weekend course, but there's subjective and objective methods. If we look at subjective methods, it's going to be analyzing the aesthetics of the patient, their resting arch positions, and their phonetics. Those are going to be our 3 kind of big methods there. We also have objective methods. That's going to be taking facial measurements, determining or calculating the amount of freeway space the patient has, radiographic analysis, and then looking at all of their clinical signs to determine if they are overclosed or they need opened up their vertical dimension. So if we look at the subjective methods here, start with aesthetics. Most frequently, you'll see a patient come in with long-term denture wear, with worn down dentures that they've had for 20 years, and you'll see some wrinkles in their skin there, or the lip commissures will be turned downward, or you'll have kind of the widow peak like on the left there, where they've just worn down their teeth and kind of collapsed their vertical. Somebody that would need to reestablish their vertical dimension of occlusion. We would also look at the resting arch position. So I like this method, especially for my wax try-ins, where you test the patient's ability to swallow. So have the patient relax. Are you able to swallow? Any difficulty? Do your teeth contact when you're swallowing? If no, then you haven't. It's kind of a guideline that you have an appropriate vertical dimension. Whereas if they're swallowing and their teeth are contacting, or they're really struggling, then their teeth are too close together and you need to create some space in there. And then phonetics. This dates back into the early, pioneering pros literature with Silverman Pound back in the day. Everybody probably does this in practice, but looking at the closet speaking space, most commonly the S sound, just have them say 66. Ideally, you should have about a millimeter between the teeth. If they're struggling to say 66, the teeth are just too close together. Again, ideally, you have a little space there for them to enunciate the S sounds. There are some atypical positions where they may be in a class 2 or a class 3 relationship, but this is a kind of a good gauge to tell where you're at with the vertical dimension of occlusion. You can also get the F and V sounds. This is going to give you the length of the maxillary incisors. Back to Pound's article in the 50s with denture teeth, where the maxillary incisors should just contact the border of the mandibular lip. So you don't want it to dig into the lip, and you don't want it to not contact there. That was determined to be kind of ideal for aesthetics as well as vertical dimension of occlusion. We then have facial proportions. So this is going to be some of the objective methods here. So there's many different ways to determine facial proportions. We talked a little bit last time about the golden ratio, but that is something that throughout the literature, people relate to the aesthetics or vertical dimension of occlusion. We have other methods. So we have, this one's Willie's method, where you look at the pupils to the corner of the mouth, and that's supposed to equal the nasal spine and lower border of the mandible. We have another one here where it looks at your hand and your thumb and kind of relates that to the facial features to determine if you're at the correct vertical dimension of occlusion. We also have divine proportions here, where it splits the face up into 3, and that should be similar to the distance between the chin and the nose. And then we have all of these measurements here, and this is all in the prosthetic textbook here. But these are just different ways that throughout the literature, people have determined whether or not the vertical dimension of occlusion is adequate in the freeway space. So by looking at these measurements, all the measurements should be similar if the VDO is correct. And then we have a Shimbashi measurement here, where they measure CEJ to CEJ of the upper central incisors, and they determine that it should be around 18 to 19 millimeters on average in people here. To just kind of summarize the facial measurements, there's many different measurements out there. In my opinion, they kind of should be used as an adjunct along with other methods. It shouldn't be where you just look at the Shimbashi measurement, and if the patient doesn't have 18 to 19 millimeters CJ to CJ, you need to alter their vertical dimension of occlusion. I think it can be used adjunctively or to kind of test the position, but there is a large variability amongst these measurements with it. Determining freeway space, this is probably one of the most common ones, where we determine the amount of space in between the vertical dimension of occlusion and the vertical dimension of rest. So this is going to be where we calculate a distance for that patient for the vertical dimension of rest, as well as the vertical dimension of occlusion, subtract it to get the freeway space. Throughout the literature, the average being about 3 millimeters there. So less than 3, maybe increase the vertical, greater than 3, maybe decrease the vertical there. So again, subtracting the vertical dimension of rest from the vertical dimension of occlusion. In doing this, the way we measure it is we first put 2 reference points. So most commonly, you'll put a dot on the nose and one on the chin. When doing the lower, you want to put it further down on the chin. You don't want their lips to alter it when they're kind of relaxing or clenching together. So you want it to be somewhat of a stable landmark. So generally put it all the way down on the chin there. You don't have to actually mark them with Sharpie. You can just put a little masking tape and then mark them with mark the masking tape. And the first thing we're going to do is measure the vertical dimension of occlusion. So you'll have the patient sit there and relax. It's important when doing this, you want them to sit about 90 degrees up and just kind of relax their shoulders. You don't want them to be tensed. You don't want them to be laying back. That's going to alter the soft tissue profile and kind of hinder the vertical dimension measurements here. So you first have them slowly close until all the teeth are in contact. Light contact, you don't want them to be clenching or stimulating their masseters. So their teeth will come in contact, relax the lips, and then you make a measurement from those 2 reference points. You're then going to calculate the vertical dimension of rest. And this is probably the most difficult one to try with patients, especially the elderly, if they have dentures or just not completely there to help them relax the muscles. So a couple different techniques here is one is swallowing or wetting the lips. So you'll have them wet their lips and then just relax, or swallow and then relax. So by that, they're kind of being distracted and then they just relax where they don't really move their teeth. The other is tactile sensation. So have them open as wide as they can and then close until the mandible feels relaxed. To me, that's a little more difficult. You can also use phonetics. So I had a prosth instructor that loved this one. He just would walk around the clinic and just yell Emma to everybody. So you just say Emma, and by that your lips are going to be kind of together, and then just after they say Emma, they just relax, and that's how you would calculate the vertical dimension of rest. So a couple different methods there. What I do in practice is I use a little tongue depressor here. So from the dot on the nose to the dot on the chin, I'll first measure the VDO. And then with the VDR, I'll have them relax. And then I just make another marking. And then I'll measure it outside the mouth with a perio probe or a roller here. You can also, this is a cool gadget from the Mod Institute. If you go to modinstitute.com, Wally Renee has a 3D printed VDO gauge that you can print. He has a free digital file there where you can actually print your own VDO gauge. So that's something that if you want a free gadget in your practice, they have it free on their website. But to me, I just use the tongue depressor. They're practically free. So again, we're calculating the free waist space, the difference between the vertical dimension of rest and the VDO, on average about 3 millimeters. We then also have radiographic analysis. So it used to be Ceph was using Cephs was the main way to check the VDO and the skeletal relationship. But CBCTs have been, really advanced, and there's a lot of good articles out there on observing the VDO and calculating it from CBCT. So it seems like there's a shift where if you are going to be using radiographs, the majority of people are using a CBCT now to do it rather than a Ceph. And then lastly, we can't overlook the clinical signs. So a patient comes in, you just kind of look at them and you can pick up a couple telltale signs. So a patient like this, where the vertical is just too much, they don't have free waist space, difficulty talking, phonetic issues, they're not really able to get comfortable, they can't really close their lips, muscles are hurting, the face has an elongated face, they can't really close their lips over it. It's going to be somebody that has the vertical is too increased. Whereas somebody that comes with a decreased vertical, somebody that's worn down their dentition, we need to reestablish it, or they have dentures that are 20, 30 years old that are worn down to the pink. They don't have the biting force they used to. They're not able to masticate as well as they did, overclosed, leading to pain in the TMJ, muscle pain. Probably the biggest telltale sign are the aesthetics. You lose the fullness of the lips, the borders are reduced, facial wrinkles, angular colitis, all signs of somebody that has a decreased vertical that we need to reestablish prior to undergoing all-on-X therapy. So conclusion, these are just some of the methods, some of the more common methods out there. With VDO, there isn't a single static and repeatable VDO position, but it's a range of possible verticals, and it's termed the comfort zone. So if you see a patient 3 days in a row, their VDO may be different each one of those days. They may come in one day, their football team won the night before, they may come in one day, they have to go to work, or they had too much coffee, whatnot. But it's going to be somewhat of a range in that comfort zone. And that's all we're trying to calculate is, are we in an acceptable range for this person, or are we pushing it where we need to raise their vertical or reduce it? Any method can be used. We must assess the vertical dimension prior to undergoing all-on-X therapy. This can't be stressed enough. You can't just put the implants in and then try to figure out where the teeth need to go later. That's just, we can't do that, complication after complication. You just can't do that. We need to assess their vertical dimension prior to undergoing all-on-X therapy. And I think that's kind of the best thing about guided surgeries. You're doing so much planning before going into these cases where you're sitting with the doctors over at ITX. We're looking at facial photos, determining, the smile line, where do the teeth need to go prior to even looking at the CT scan. We're doing all this work beforehand. And that's how it should be for these all-in-X cases. It shouldn't be, oh, I got 4 implants and now let's figure out how to connect teeth to it. And when we're doing this, when we're trying to assess the vertical dimension, we do this at the try-in appointment. So when you're doing that wax setup, or you're putting in the PMMA prosthesis for the patient before the final zirconia, this is when we're confirming that we have the correct vertical, the tooth position, speech patterns, jaw relations. We don't do it when we insert the final prosthesis and then try to figure out, oh, now the speech is off. Now we just start grinding teeth. We do this at our try-in appointments or workup appointments prior to going to the final restoration or putting in the implants. So we talked about how to assess vertical. Now we have cases where we have to alter the vertical dimension of occlusion. There's 2 schools of thought where on some people you do not alter, absolutely not, and then others you can alter. So when do we want to alter? When can we alter the vertical dimension of occlusion? In some cases, we may have to for restorative space. The patient just doesn't have enough restorative space, so we open them a calculated amount. We test it to make sure they're able to accommodate it, that it suits them, and then we go to the final restoration. Attrition, this is going to be our probably biggest one. Somebody comes in, worn down all their teeth. We first need to establish where their teeth need to be. So where is that incisal edge position? Do we need crowny lengthening, or do we need to lengthen the teeth to reestablish that vertical dimension of occlusion? Force issues, somebody that comes in and their TMJ is just, it's a hot TMJ, and we determine that it's due to the vertical dimension of occlusion. And then aesthetics, somebody comes in there, the borders of their lip, the vermilion borders are all sunken in. We need to reestablish their vertical for the correct soft tissue profile. And when do we not alter them? Patients with significant parafunction. So this person's masseters have created hypogonadal notches there, kind of wearing out the bottom of the mandible there. We need to kind of avoid or do it very calculated, altering the vertical dimension of occlusion on this person. This isn't somebody where we just take the articulator and just crank it open to a magic number. Dentoalveolar extrusion. This is a kind of interesting thing that I see a lot in my practice from referrals, where the anterior teeth have wear and there's no wear on the posterior teeth. So their anterior teeth have continuously super erupted. So their anterior teeth are at the correct position as far as mandibular and maxillary tooth position. However, they have no tooth structure left. So this isn't somebody that we just add composite or add restorative length to the entire arch. We need to go in there and remove gums and do crown elongation. They're at the correct incisal edge position due to the super eruption. So this is somebody that we cannot add length to. We need to create length through periodontal procedures. Poorly positioned implants. Just because a patient walks in like this, where they're smiling and all you see are their gums and their locator tips, we don't just make teeth that snap into those. We need 12 millimeters on top of those locators. So a patient like this, we're not going to just alter their vertical dimension of occlusion to put teeth in there, because the patient's not going to be able to function with it. So that's where it goes back to determining the vertical dimension of occlusion, where the incisal edge position needs to be, goes prior to placing implants into these patients. With these, when altering vertical dimension of occlusion, there is an adaptation period. So anytime you're going to be changing vertical dimension, there is an adaptation period. The greater the vertical dimension increase, the greater this period will be. There's also going to be a longer period for somebody that has implants, as opposed to somebody that has natural teeth or is a dentulous. With implants, they don't have the proprioception that they do when they have their teeth. So we have to give these patients a little longer time to be able to adapt to ensure that we're at the correct vertical dimension of occlusion. And then this is a very important topic here with the 1-2-3 ratio, determining opening vertical dimension of occlusion. So if you open a patient 1 millimeter in the posterior, that pin of the articulator is going to be open about 3 millimeters. We're also going to increase the overjet by 2 and decrease the overbite by 2 millimeters. So 1 millimeter in the posterior does not mean we gain 1 millimeter in the front. So be very cautious of just jacking somebody up to create space in the posterior, because you're really going to open them up in the front. And that's due to the way the mandible opens through the condyles there. So that's a very important topic there, and understanding with when opening a patient up to create room. To summarize vertical dimension quickly here, there is no exact single technique to assess VDO deficiency. We went through 7 or 8 different topics there, some objective and some subjective. You can use one of these, or you can use all of these in each of your cases to determine if you are at the correct vertical dimension of occlusion or that patient needs open or closed. There's strong evidence that patients can adapt to modifications to the vertical dimension. There is an adaptation period, and not every patient is the same. You can't just have a set number where I can open every patient in my practice up 5 millimeters. You may be able to open somebody up 5 millimeters, but the next person may not be opened up at all. With this adaptation period, it's longer for implants, and the greater the increase, the longer that period should be. There's, again, a wide range of changes in the vertical. Do not treat all patients the same. Not every patient should be opened up the same amount there. And again, it's safer to reestablish the vertical prior to undergoing implant therapy, especially with these all-on-X cases. We really need to sit down and kind of look at it, get our mounted models, take our photos, and really figure out where the teeth need to be prior to starting to analyze that CBCT and determine where the implants need to go. With that, we'll now jump into the mandibular tooth position. So we've set our maxillary anterior teeth. We've determined the vertical dimension of occlusion, the amount of freeway space that patient has. Now, where do we put the mandibular teeth? So how much lower teeth should the patient show? There's no real consensus on this. What I use is evaluate the patient pre-op. So look at their pre-op photos, ask the patients, when you had your teeth, did you show any of the lower teeth there? If they say, yes, I showed, gums, then you know kind of how high those are. If they didn't show anything, then you kind of have a guideline to go off of. It's kind of a rule of thumb here that as the patients age, they will show more of their lower teeth, less of their upper teeth as the muscles get weaker and continue to sag. So over time, patients will start showing more of their lower teeth with it. Probably the biggest thing to look out for here is combination syndrome when dealing with these patients with terminal dentition, where they have an upper denture and they have their lower anterior teeth that have continuously super erupted. We really need to be careful of this because we need to figure out where that incisal edge position needs to be. It's not going to be the red line there where it's at right now. It's going to be closer to where that green line is. So with the combination syndrome, that patient's lower anterior teeth have continuously super erupted, feeding into that upper denture there, creating a deficiency in the anterior maxilla and continuously growing there. So we need to reestablish where that mandibular tooth position needs to be prior to starting to plan where our implants need to be placed. The mandibular tooth position also plays a key role in incisal guidance. So as well as the maxillary anterior tooth position, if the lower teeth are positioned too high, it's just going to put too much force on the anterior teeth. Whereas if the lower teeth are positioned too shallow, now it's going to lead to excessive posterior contacts. We also have steep and shallow anterior guidance. So if somebody has a very steep anterior guidance, so they kind of have a deep bite, they're going to have easier posterior disclusion. Whereas if somebody has a very shallow anterior guidance, they're going to be riding more on the posterior with that. So just something to be cautious of. And then there are certain cases where we need to establish anterior guidance, and that's done by hypercontouring the lingual of the maxillary anterior. So if we have our maxillary anterior tooth position set and we have our lower anterior tooth position set based on the vertical dimension and aesthetics, and they're not contacting, so you're not getting the anterior guidance you need to. There's some cases where you actually have to bulk out the lingual to create ideal or proper anterior guidance to prevent posterior disclusion. So mandibular tooth position depends solely first on the maxillary tooth position. It dictates anterior guidance, and lastly, determines aesthetics of the case. Lastly, we're going to look at the occlusal planes. Non-ideal occlusal planes can range from just a couple millimeters to completely sideways. There's lots of ranges of these, and you'll run to a patient that walks around where their teeth are, set at a 45-degree angle and they don't care. And then you have the other patient that comes in and the upper bicuspid is 1 millimeter too short and they think the world's going to end here. So just things you need to look out for here. So ideal occlusal plane dictates the smile line, aesthetics, phonetics, soft tissue profile, biomechanics, allows proper movements of the mandible as well as mastication, endless benefits to establishing an ideal occlusal plane. One thing that works great are these occlusal plane analyzers. It gives you kind of a starting point, establishing the curve of Wilson and curve of Spee, going back to setting denture teeth. This is something that translates to fixed prosthetics as well as implant prosthetics. So this is a great tool, the occlusal plane analyzer. And then you can even do this digitally now. So within exocad, you can mount your cases on a sophisticated articulator, put the occlusal plane analyzer in there, and get the teeth at the appropriate contours there for proper function, mastication, and function there. So we need to recognize poor occlusal planes. Again, the super rupture of the mandibular anterior teeth, that is very, very common, especially in people that have upper dentures there. We need to establish where the lower teeth need to be, where the occlusal plane needs to be. And for these all-on-X cases, it shouldn't be, we're just going to treat one arch and then we'll ignore the other arch for 5 years and then do it. We need to treat both arches for these cases. Patients are putting in lots of time, money for these procedures. They're very invasive. So we need to make sure that we have set them up for long-term success. So always kind of look at both arches. Don't just stare at the lower teeth that are failing. Look at what the upper teeth look like, where the aesthetics and phonetics and function of those are. Now that we went through our little protocol on how we treat maxillomandibular relations, how do we establish this for all-on-X surgery? So a patient comes in, they have failing dentition like this, and we want to take them from that failing dentition and give them a brand new smile, brand new bite, full complement of teeth. And we want to do that in 1 day. So we're going to clean house, take out all the teeth, remove bone if we need to for restorative space, place the implants, and then fixate teeth to those implants. How do we do that predictably at the correct relationship for long-term success? And it depends on the type of conversion. So we have different methods that we can use to help correlate this relationship or establish this maxillomandibular relationship. And that's going to depend on the conversion that we're going to be doing. So how are we going to take that patient's implants and put teeth into it that day or the next day or 1 week later? And we'll go through each one of these. So the first one is going to be through a chairside denture conversion. So a patient comes in, we're putting the implants in, we can do it guided, we can do it freehand, and then we're going to take a denture. It's either going to be the denture that they come in with, it's going to be a duplicate denture, or it's going to be an immediate denture. So somebody that comes in failing dentition, we make them an immediate denture based on our maxillomandibular relation protocol, and then we're going to fixate it to the implants and the temporary abutments that day. One of the problems with this is stabilizing that denture after the surgery. So this patient down here on the bottom has 4 teeth left on the lower. We're removing the teeth, reestablishing or recreating where the mandibular and maxillary teeth need to be, and then we're placing implants. So we have an immediate denture that's made where the teeth are not where they're going to be preoperatively. They're going to be a lot lower. We're also removing, in this case, we're removing about 10 millimeters of bone. So how are we going to get that lower denture stabilized prior to converting it to those implants or connecting it to those implants? And we also have this issue on the maxilla. So this maxillary case here, you have this very invasive full thickness flap here to get 6 implants in. And then we're going to suture the patient up, and then we're going to connect a denture to it. But how are we going to be able to do that? Because we're going to have some changes in the bone. We're going to have some change in the soft tissue after this procedure. How are we going to stabilize that denture after the surgery? And we start with the maxilla here. So maxillary conversions are a lot easier because you have the palate. Similar to when you're doing an immediate denture, maxillary denture is always going a little easier because you have the palate as a landmark. The palate's not going to move. It's kind of a fixed stress-bearing area. Yes, there may be some inflammation from the surgery, from the anesthesia, but it's going to be pretty steady there. Whereas the lower, it's kind of just float there. So Things are a little easier on the maxilla because the palate is stationary. So when you're going in there to seat the maxillary denture, you want to make sure that there's intimate contact with the palate. You can use PIP paste to ensure that when that denture is going in prior to connecting it to the implants, that there's markings on the palate there, that denture is fully seated. Because if it's not fully seated and you go ahead and convert that prosthesis, that incisal edge position is going to be way off because it was made to the model or the master model against the palate there. So if that denture isn't onto the palate, your incisal edge position's off, your vertical's off, everything's going to be off at that point. So first thing with maxillary dentures is before connecting it to the implants, you want to make sure that that's fully seated. Another technique I utilize is after I determine that my denture goes in passively, it's not getting caught up on the multi-unit abutments or the temporary cylinders, and there's contact on the palate, is I will sometimes add some bite registration in the anterior. So this is done prior to picking up the temporary cylinders. So that patient will have, I'll have the multi-units on there, I'll have the temporary cylinders in there with my holes already drilled. I'll make sure it goes down to the palate. And then what I'll do is I'll add some bite registration in the anterior there, because that anterior is going to change regardless if you're removing bone or not. So that denture may have fit perfectly before, but you're opening the gums up, putting your implants in, removing bone, suturing it back together. Now there's a little void there from the anterior. So what I'll do is I'll add a little bite registration in the anterior there. I'll then take it to the lab and I'll hollow out. I'll leave the bite registration in there, but I'll hollow out where those temporary cylinders are. So when I put it back in the mouth, the temporary cylinders come out through the holes, but that bite registration is still in there. So I'm kind of using that bite registration as a reline material in the anterior. So now I have a palatal stop. I also have an anterior stop. So now it's a lot more stable, whereas before it was just resting on the palate. Now it's resting on the anterior. So that's something that I do on my denture conversions that give just a little more stability prior to that pickup. Mandible is a little more difficult. So the mandible, it's very common for us to take out the lower teeth, especially the lower anterior, remove some bone to gain restorative space, as well as width, place the implants, and then connect the denture to those implants. With it, we're removing bone, and just off the bat, lower dentures don't really fit great, especially immediate dentures. So we're already behind the 8 ball here. So stabilizing the denture after implant surgery can be quite cumbersome and difficult. So with the lower denture, we don't really have the anterior vertical stop because we're always placing implants in the anterior segment. We don't have the palate that we can rely on. Really, the stress-bearing area of a mandibular arch is going to be the buccal shelf, but you really can't get too much stability from holding the denture back in the buccal shelf area. We need something in the anterior, and that's where using bite registration, similar to what I talked about on the upper, really helps out stabilizing these dentures. So after I drill my holes in the denture, I'll fill the denture up with some bite registration. I'll then seat it in the mouth, kind of get it at the correct vertical dimension of occlusion, remove it, and then I'll hollow out those holes, pick up the temporary cylinders, and then after those cylinders are connected to that denture, I'll then take it to the lab, remove the bite registration, and then add more material in the intaglio and create a cleansable prosthesis for the patient. So that's just a couple little tips that I use on stabilizing these dentures for these chair side conversions. Next, with the denture conversion, we have the denture stabilized. We have make sure it's kind of in intimate contact. How do we get the correct relationship? So we have this perfect denture setup that was done on exocad, or our lab tech did it on an articulator, and now we need to replicate this in the mouth. But our surgery's just been 2-3 hours. The patient's numb. Nobody wants to be there anymore. How do we get those teeth in the correct spot? So first, we're going to ensure that that denture is fully seated. So similar to what we just talked about there, I like using bite registration to make sure that that denture is going in there passively. So use it to show you where you need to drill to allow it to seat over the multi-unit abutments as well as the temporary cylinders. Make sure it's fully seated. And then once it's seated, I like using a check bite there. So, and sometimes you can even make a check bite before, or the lab will give you one. So when the dentures are made on the articulator, they'll actually send you a bite registration. So when you put them in the mouth, you can have them bite into that bite registration to make sure you're at the correct relationship. So but you can easily just make one in the mouth there. So as you get that denture seated prior to converting it to those implants, have the patient bite down. Okay, that bite looks great there. Let's do a bite registration, because they're biting down once. They might bite down the second time forward. They might bite on the right, on the left, especially if a patient's jaw is kind of not cooperating, or a long procedure again, patient sedated. How do you get that patient to bite in the correct spot? Using a bite registration really helps there. And you can actually use it even through the pickup. So prior to converting it to the temporary cylinders, create your bite registration. Okay, now we're going to route the denture to the temporary cylinders, put the bite registration back in, have the patient bite into that, and then add your material in there. So you're ensuring that you're at that correct maxillomandibular relationship before connecting those temporary cylinders to the denture. You can also pull out the tongue depressor. So we have our VDO and our VDO and VDR with the amount of freeway space. We have the markings on the patient. So as that patient's biting into that bite registration, let's check and make sure they're at the correct spot there. Are they biting down too much, or is that denture moving in the mouth? Or is it getting caught up? Are they biting down and their spots aren't lining up there? So this is another method that you can use, and you can even do this at a pre-op appointment. So patient comes in with perfect dentures. We're going to just place implants, get their VDO and VDR then. Yes, it may change a little bit throughout the next couple of days or during the surgery, but that's going to give you kind of a baseline of where you're at. If you're way off, then something's going to be off here. So you can even use the little analyzer like this, like a tongue depressor, to check the vertical dimension of occlusion. So denture conversions work great, but they are kind of old school. There's a lot easier methods to use that are less labor lab intensive with it. And one of them is going to be with these stackable surgical guides. These have kind of really revolutionized the industry. ITX does a great job with their all-on ITX solution here, where you have several different guides that are interlocked into what's called a foundation guide. And your bone reduction, your implant placement, as well as your prosthesis conversion is done through this foundation guide. So with these stackable surgical guides, these all in ITX, it's a top-down treatment planning. So the first thing we're looking at is that maxillomandibular relation protocol. So where do the teeth need to be prior to even looking at the CBCT? We're analyzing the patient's smile, their freeway space, where the teeth are. Do we need to lengthen the teeth? Are we at an appropriate spot there? What are their aesthetics like? Now we have that figured out. Now we work backwards. So we have the teeth set. Now we work down to the CBCT file and plan the implants. Do we have enough restorative space? Do we have adequate bone? Is this implant coming out of an appropriate position? Do we need an angled multi-unit? So this is all done prior to going into the case. In these cases, the workup on them takes a very long time, but it's done to make the surgery and the overall result a lot more predictable and faster in the long run. So this is a great case by one of our Institute faculty members here. Patient has terminal dentition on the top and bottom. You can see they're kind of over close. They have that really deep bite. So he did a great job of reestablishing the tooth position prior to going into surgery. So he edentulated the patient through a stackable guide here, took out all the teeth, bone reduction, implants placed, teeth converted at that new vertical dimension of occlusion. The patient goes home that day with a fixed set of teeth on the top and bottom there at a new vertical dimension of occlusion, not where they came in with. So the whole stackable guide all-in ITX solution revolves around the sitting in the foundation guide. That's going to be our first guide that goes in the mouth, and that's going to set the tone for the entire case, not only the surgery, but also the prosthetic conversion. And if that foundation guide is a little off, your end result is going to be a lot off. So making sure that foundation guide is seated accurately is kind of the entire procedure. So accurate seating of that will lead to accurate, predictable prosthetic conversion at the end here. So the first thing we do is we seat the foundation guide. We can use teeth to position it, or we're going to use the bone to position it. So ideally, patients that have teeth in the mouth that are in not periodontally compromised at the moment, we can use them to stabilize the foundation guide. Other times we'll use bone to do it. But the first thing we're going to do is seat that foundation guide. When we're seating the foundation guide, what I like to do is when I have it seated, I kind of take a step back and make sure it's parallel to the patient's eyes, because everything from that point on is going to be going into that foundation guide. So if that foundation guide is at a 45-degree angle and you keep going, your teeth are going to be at a 45-degree angle. So we really need to, when doing these cases, the majority of the time is put into making sure that foundation guide is accurately placed. After that's in there, you can't close an eye, but you can almost close an eye and continue the procedure. So making sure that's in the correct spot sets the tone for the entire case. After the foundation guide's placed, we then use that as our bone reduction guide. So we're going to reduce bone if needed to the level of that foundation guide, and then place implants using the foundation guide through the implant guide. And then eventually the prosthetic conversion goes into that foundation guide. So here the implants are placed. We then take a pre-made PMMA that ITX makes from us. It goes into that foundation guide. We have a check bite to make sure we're at the correct relationship, and then we convert the prosthesis. So rather than dealing with a denture that is moving around in there or adjusting all the contours of it, this has two little Lego pieces that just connect together. So it's very, very easy. And the conversions with these all stackable guides take 10, 15 minutes, where a denture conversion is 2 hours, and you're running back and forth to the lab. You need to change your scrubs because you have acrylic all over you. They really make these simple, and they're really fun to do. I mentioned that we sometimes use bone foundation guides. If they don't have teeth, we started going up to the nasal floor, and to me, that works very, very well. Even when they have teeth, just go to the nasal floor there. It's a very repeatable position. It's cortical bone up there, and there'll be two little hooks on the guide that you'll stabilize to seat the foundation guide. So something that ITX does that don't really see anywhere else out there that has worked out very well. And I really enjoy doing the nasal floor guides. We do them at our hands-on course, usually a couple of them that work very well. But again, when doing this, we're taking a step back prior to solidifying that foundation guide to make sure we're parallel to the eyes. To me, that's kind of how I use it as a test to make sure it's at the correct position there. So stackable surgical guides, multiple guides that interconnect, starts with seating the foundation guide. We then remove the teeth. We do our alveoplasty to the level of the foundation guide if needed. We place our implants through an implant guide, and then we convert the prosthesis. All this is done guided, pre-planned, calculated. So we have top-down treatment planning. So when this patient's a great all-in-X candidate, before we even start planning the implants, we're looking at where the teeth need to be. That's how these cases work. When you send ITX a case, you're sending them many, many photos, your side views, frontal views, full smile, relaxed. We're doing top-down treatment planning. We're setting the teeth digitally prior to going back into the CBCT. Precise calculated implant placement. We're getting those implants emerging at the correct orientation. We're not just seeing how big of an angle we can place them to increase the AP spread and then realize that the teeth are coming out at the incorrect position or invading the tongue space. That's a common one where the implants are coming too far lingually and then their tongue doesn't have room and they have phonetic issues. This is all done precise, calculated, and guided maxilla-mandibular relations. We're not having to deal with the conversion, making sure it's seated, making sure it's repeatable. Because every time you take that denture in and out, that patient's going to bite a little differently. They're numb. It's a long procedure. They're usually sedated. With these stackable guides, it's just going into that foundation guide. That patient can be, on the moon, and you can get it in the correct position there because that foundation guide is done calculated. Our last conversion option are the digital conversions. This is something that's new, and kind of every week there's a new technique or method. But we have photogrammetry, we have the OptiSplint, Instarisa, all different techniques to get a digital orientation of the implant position. And then once you have the digital calculation of where those implants need to be, through our digital workflow, we're able to create teeth that go into those implants. So this is done without converting anything in the mouth. It's done through some sort of digital impression to get that implant position. And then from there, we work through maxilla-mandibular relation. So with it, implants are placed, we're taking our digital impression, we get our implant orientation in regards to some sort of axis. So we know these are where the implants are. We then go through our design, our CAD software. We design teeth that go into those implants, and then we send it over to the manufacturing, and we print the prosthesis or mill the prosthesis to be inserted in the mouth here. And a lot of this can be done in one day. It just takes a lot of planning, pre-planning here. So here, digital record. This is used in photogrammetry at one of our hands-on courses to record the 3D implant position. Now with photogrammetry, it's just going to give us that position within a XYZ axis. With it, we don't have anything in regards to vertical or the maxilla-mandibular relation. So how do we relate these 4 implants in regards to the protocol that we discussed earlier? We're left with just implants in space, but how are we able to get teeth at the correct incisal edge position or the correct vertical dimension of occlusion? And with that, the starting point for all of these digital cases is with a pre-op wax up. So a patient comes in like this, failing dentition, teeth all over the place. We're going to figure out where the incisal edge position needs to be. We're going to figure out where their vertical dimension of occlusion needs to be. We're then going to go to the mandible, set the mandibular teeth, and then look at the occlusal plane. So this patient with an exocad, we edentulated him. We set teeth at the correct position as far as aesthetics, function, restorative space, and then we work backwards. So we have this done prior to going into surgery. So we start with our pre-op wax up, and this is similar to what we do with the stackable guides with the all-on ITX. They're doing this prior to designing the case within the CBCT platform. They're doing their pre-op wax up. They're translating that over to the DICOM file, and then they're planning the implant position. That's what we're doing here. It's just we're going to convert it digitally. So, and the way we convert it digitally is through digital cross mounting. And we have different methods that we're going to utilize to take that pre-op wax up and connect it to our implant impression there, our digital implant impression. First method is going to be for the denture workflow. So we have a patient that we put the implants in, and we took our digital record, whether it's photogrammetry, OptiSplint, we have that record. We have a patient's denture. What we're going to do is we're just going to take an impression within their denture, a little reline impression. We're going to scan it, and then we're going to connect that denture image to our digital impression. And we're going to kind of marry the two objects together or cross mount them. And now we have our digital impression that gives us the accurate implant orientation, as well as where our tooth position needs to be through our pre-op denture, whether it's an immediate denture or the patient's existing denture. Another method we could use is through fiduciary markers, where we can put tent screws in the palate or in the retromolar pad. And these tent screws are going to relate the pre and the post-op implant placement. So we'll put the fiduciary markers in before we even do the surgery. We'll take an impression or a digital scan. We'll do our surgery, then we'll do another one. Now we have a before and after. So as we do that pre-op wax up, we have it with the fiduciary markers. Then we have the post-op with the fiduciary markers, and we cross mount them or connect them together here. So here we have on the left our pre-op. So we have our wax up that we did digitally with our fiduciary markers. Then we have our post-placement record with the fiduciary markers, and then we just connect the fiduciary markers. And then we're able to correlate that pre-op wax up to our post-placement implant record. We also have cases where we may be able to leave select teeth to act as fiduciary markers. So we'll leave 1 or 2 teeth, and we'll take our pre-op record with their teeth in there. We'll take out the teeth, place the implants, leaving 1 or 2 teeth, take a post-op record, and then you're able to use those teeth to marry the objects together. And then you can also use a converted prosthesis. So this is using the OptiSplint, where you actually convert the prosthesis, and then you could take a scan of the patient's converted prosthesis and digitize that file. So you're able to get the maxilla-mandibular relation through that converted prosthesis. And the newest one that just came out is through Straumann RevX. That looks very promising. That works on this workflow of taking a prosthesis that's converted in the mouth, whether it's a denture conversion or a all on ITX, and you can put scan bodies in it and scan it, and then you get a accurate file of that. So that's something that just came out from Schramm and RevX. So we have one of these methods that we're going to use to correlate the implant position with our pre-op wax up. So we're going to combine all these records together. So we have our pre-op record, we have our implant record, and then we have our post-implant record. We marry all these objects together, cross-mount them, and then we're able to design our case. So we design the case based on that pre-op wax up. We create the appropriate contours, and then we send this case to our printer or milling unit for CAM manufacturing, and we deliver it in the patient's mouth. So using these digital conversions, it's a fully digital workflow. Everything is done digital. So all the planning, design, manufacturing is done digitally. With it, the big benefit is you kind of have a digital file of the patient's prosthesis and master model. So complications happen. If anything happens while they're healing, you can just print or mill another one. So it'll go right in there. You also have a master model of where those implants are. Those implants, they're not going to move. So if you have an accurate implant impression, you're going to have that accurate implant impression digitized 4 or 5, 6 months down the road when they're done healing. So we have that kind of permanent digital master model in the aesthetics occlusion vertical. With these cases, similar to the stackable guides, they're practically spot on, because we're doing all of these adjunctive measures of taking photos, incorporating them in the design with it, and we're doing this all calculated. So the aesthetics occlusion vertical is a lot easier to determine and maintain compared to denture conversions. Lastly, there are some other digital methods that we can use to enhance the maxillomandibular relations. This is a good article by Ravilla that looked at static and dynamic methods. You can create a 3D static patient through any digital info. So take a picture of your phone and you can kind of create a 3D static version of them, or facial scans, CBCTs. Whereas there's some ways to create a dynamic 3D patient where we actually incorporate the patient's movement, and we can utilize that in creating maxillomandibular relations or setting teeth for these all-on-X cases. So if we look at static, one of the static methods out there is Instarezo, where you take a intraoral scan as well as an extraoral scan, and we're able to get a kind of static representation of that patient as we set their teeth and make sure we have them in the correct position as far as aesthetics and function. Other methods out there, the Ray Face is another one that is a facial scanner that gives us a static representation that we can utilize to enhance us placing teeth in the correct position. Then there's dynamic methods out there. So there exist jaw motion tracking systems, and there's a lot of good articles throughout the literature that look into this. This article looked into doing it for an edentulous case. So you use special trays and you put it in the mouth, and then you take a record of the patient. You're able to get all of their mandibular movements through these scans and facial trays here. So you're able to kind of digitize everything, and then you have a digital representation of all of their movements here. And then kind of the most recent one that you'll see out there is ModJaw. This is where they call it bringing life to 4D dentistry, where we're able to get all of their mandibular movement. So we hook the patient up to the monitor like this, and we have them open and close. We have them move laterally, and we're able to kind of get tracings of all this, as well as it'll show us which teeth are contacting as you do it here. So this is a way that we can kind of really enhance for these all-on-X cases here, enhance our maxillomandibular relations. So we covered a lot tonight, went through it there. So just to kind of finish with some take-home messages here, the starting point for all these cases is always going to be the maxillary anterior teeth. It dictates phonetics, aesthetics, function. Even if we're just doing a mandibular all-on-X, always look at the maxillary anterior teeth and see where they're at. Don't just focus on one arch. Always look at the maxillary anterior teeth. As far as the VDO, not one method is superior. We must evaluate clinical signs, so don't overlook just taking a step back and looking at that patient from a couple feet away there in the VDO. There's no single static vertical dimension of occlusion position, but there is a range of possible VDOs, and that's kind of the comfort zone. So you're not going to get one position every single time, every day for that patient. It's going to be a range of comfort for them, depending on the time of the day, how they're feeling, and all that there. When going into these all-in-X cases, it's safer to reestablish the vertical prior to implant therapy. So if you're questioning where those teeth need to be, give the patient a denture, edentulate them, bone graft, put them in a denture to make sure you're at the correct position prior to putting implants in. It's a lot easier to make a new denture than it is to take out 4 implants and reduce bone and then put them in a different position. So, it's always safer to reestablish the vertical prior to placing implants in and then figure out where they need to go. And then when we're doing our all-in-X conversions, there's different methods that we use to take this protocol and correlate it to the implant placement. Denture conversions, I love using bite registration to not only orient the correct occlusion, but also create some stability within that denture. Stackable guides, they really revolutionized everything with these full arch cases, but everything hinders on the accurate seating that foundation guide, so that can't be overlooked. And the digital techniques, the techniques keep getting better and better. There's new products, every time the journal comes out there, but they all kind of do the same thing, and they all kind of have the basic principles, but you also have to understand that all of those new digital principles still relate to the analog methods. You still need to be able to establish the correct maxilla-mandibular relation of that patient. It's not going to do that for you digitally. So you still need to be able to determine the amount of freeway space that patient has prior to, going into your photogrammetry record. Thanks again to ITX for having me again tonight. They do a great job with our institute as well as in my practice. I use them practically every day. I'm talking to Hussein 2-3 times a week here, reviewing cases. So they're top notch. It's amazing how quickly they get you these guides and how accurate they are. And they're really fun to just, try these on these big cases or these edentulous arch cases. We use them throughout our entire institute curriculum, as well as our hands-on, and our doctor's very appreciative of it there. So thanks again for having us. And then we are out in our Texas session here. So we have our next session in October. We do have another course that weekend. So we have 2 courses that weekend where we start with a CBCT boot camp, where we go through how to read CBCTs, all the anatomy, and then we go through guided surgery. So we spend a half day going over guided surgery, some of the digital techniques of 3D printing, all-in-X photogrammetry, dual scan. We go through all that. And then that weekend is our edentulous arch weekend. So, and we actually have a stackable guide that weekend that ITX has created for us. So we'll be doing that one of the days. So where we focus on placing implants in edentulous ridges there. And then we also have our complications course in February in Vegas with that there. So you can find all that information on our website. Okay, AK, you want to take over and say anything?
Yes, sir. We've got, well, this presentation was so informative, and definitely we have a lot of questions today. I'll start with, how did you transfer the condylar inclinations to your treatment planning?
Yes, so that's going to be with a face bow. So we still use face bows with these bigger cases. So I use a face bow for all of these all-in-X cases. So to transfer it to the articulator, whether it's a freehand articulator or a digital articulator. So we're still going to be using face bows to transfer that.
Gotcha. You've talked a lot about digital dentistry today. Is there a way that we can determine the vertical dimension of occlusion within the digital workflow? Is there a digital way, or you still do some analog work there?
So everything with the digital method still works off the analog method. So we can use our facial scanning. We get the full facial profile of the patient, which is going to show us their facial profiles, their soft tissues, but you still need to be able to put wax rims in the mouth, have the patient say 66, and make sure they have enough space in there. So in my opinion, you still need to be able to do things the analog way before just jumping into the digital workflow with it there. There's ways that we can adjunctively enhance our setting the teeth digitally through facial scans, jaw motion tracking, but we still need to be able to sit there with the patient and make sure we're at the correct vertical dimension of occlusion.
Gotcha. And in the same topic, or then the same topic, what do you do for digital convergence when the maxillary mandibular relations are so off?
Yes. So what's nice about kind of digital conversions is if the maxillomandibular relations is off, we still have the accurate implant positioning. So what I'll do is, let's say we print an upper and lower prosthesis and we put it in the mouth and the bite's off or they're not showing enough upper teeth. You can take a new record of where those teeth are. So you'll take an intraoral scan, or you can take an impression, digitize it, and then you'll put that into the design software as well as with some facial photos, and you can just increase the teeth digitally there. So, instead of sitting there on your lab bench and moving wax teeth, we're able to drag them down digitally there to create them in the correct position. So we'll kind of do like a digital remount of the case, and then reset the teeth. And using photos really helps a lot, especially with like the midline's probably the most common thing to go wrong there, where you'll put the teeth in the midlines a little off. You just take a photo of the patient, and in the design software, you just put a line right down their face and you can reestablish that. So yeah, it's a little easier in the digital realm to kind of reestablish it there, because you just design it, then you just hit print, and each print costs you, $10-15. So it's and it can be done in minutes. So it's not really that time consuming.
Gotcha. What is the maximum that you can open somebody's video?
Yeah, that's a good question. Like it depends on everybody. So, I may be able to open the vertical on you 5 millimeters, but on Robert, we can't open the vertical at all there. So, everybody's different with that. You need to treat each case differently. Not every patient is a candidate for opening the vertical. And when we're deciding whether we open the vertical or not, a lot of it, I think, goes back to what happened to their teeth. Did they wear their teeth down and their teeth just super erupted? So are their teeth at the right spot? It's just they're very short. Or did they wear down their teeth and they have a ton of room to add teeth to it there? So I think a lot of it goes back to that, is figuring out where their tooth position needs to be and then kind of work from there.
Gotcha. I mean, you talked a lot about the video and and it shows how important it is for reestablishing the full mouth reconstructions. So it seems that it has to happen case by case from what you just said.
Yes. Yes.
Another question that I have for you: do patients lose their maxilla-mandibular relationship when they are edentulated?
They can, yes. So that's and my father will talk about that a lot in the complications course, where he terms it wandering jaw syndrome, where a patient becomes edentulated and they're not giving interim prosthetics, and then they come back and you try to make them a denture. You go straight into a conversion, and they can't find where their teeth need to be. And so yes, that does happen on people that, and it could be as little as 3 months where they're not with a denture and they can't find where their jaw needs to go. So we really encourage and advocate that anytime you're edentulating a patient, to make them an interim denture, and really encourage them to wear it to ensure that they maintain that correct relation, because it's a lot easier to make a patient a denture or go to an all-on-X when they have something in the mouth. When they come in with nothing, especially after 20 years, it's very difficult to determine or get them to bite into the same spot repeatedly.
Gotcha. One last question: can you do a stackable guide if you're changing the vertical dimension?
Yes, you can, and I think that's when you're doing it, as long as you're doing it calculated and precisely, I think that's the safest way to do it. I think if you're going to be doing a denture conversion, trying to change the vertical, it's going to be very difficult, because as I said, you're losing that vertical stop there. With a stackable guide, we're first looking at our photos, designing the teeth in the design software. So we're setting where the new teeth need to be. And then after you guys have set the teeth, we then send that over to RealGuide, and then we start designing where the implants need to be, and then we start designing our surgical guide. So everything's done based on that altered vertical dimension, and we're using that foundation guide to transfer the data from that altered vertical dimension to the patient intraorally. So I think whenever you're reestablishing vertical or altering vertical, using a stackable guide is a no-brainer.
Understand you. I mean, you've talked a lot today about the importance of having this full prosthetic view of the case before we even move forward with any surgical approaches, which I think makes a perfect sense. You've always talked about the top down approach, top to bottom approach when it comes to simpler cases, but it looks like it's even way more important with full arch, full mouth rehabilitation.
Yes, yes, it is, especially when you get the implants in and then you have to figure out where the teeth need to go. That's just a bad day. So
Yeah,
figure
of
out where the
course.
teeth need to go and then get the implants in the correct position using an ITX guide.
I know.
Yeah.
We're we're way out of time here,
Yeah.
so I'm sorry. I'm gonna let you go. Beautiful
Yeah.
Harper right
Yeah. I
there.
told you there's her dolphin. So yeah, that's when they didn't get over 70
And they're
points. She
doing
wasn't
good this
happy.
season, so maybe it's
Yeah.
her.
Yeah. So we'll see. So we're going to get her some bigger clothes. So,
Yeah, I know. Thank you so much, Chris.
okay.
And
Thanks,
thank you for
Doc.
all the information. Beautiful presentation. Thank you so much. And
Thank you.
thank you for everyone for attending this. And I would like to also thank Dr. Robinette and Dr. Tara Resnik for being part of this panel. Also thank Dr. Hussein Tariq, Dr. Peter Ihab, and definitely Dr. Milad. Thank you so much for being here. And thank you so much, Chris.